Hi, I'm Nick Schenker. I'm the senior author on the British Society for Guidelines on Pain Management for People with Inflammatory Arthritis. I'm a consultant rheumatologist in Cambridge, and I shared the co-chair of the guideline working group with Dr. Ian Scott, who's based in Kiel, the University of Kiel, as a senior lecturer in NIHR. Pain management is really important for our patients with inflammatory arthritis. We know that about a third of all of our patients have persistent pain despite good disease control. We know that the science has caught up. The last time we tried to do these guidelines was 10 years ago. There's been an awful lot of systematic reviews and evidence published that we've put into the guideline. So the science has caught up, and we feel that the guideline now reflects the perfect time to launch and improve pain management for our patients. We also know opioid prescriptions are about static and very high, and gabapentinoid prescriptions are going up. And there's the evidence base for giving gabapentinoids to patients with inflammatory arthritis is very weak, and of course there are dangers with that as well as costs. You have to assess your patients with inflammatory arthritis for inflammation. However, by doing that, you're not taking a holistic pain assessment. This guideline is the first guideline that actually outlines how to do a holistic pain assessment. And read the guideline very carefully will allow you to do that. I think perhaps the most surprising aspect of this is I would hope people have slightly different conversations and connections with their patients. I've certainly found that. I would strongly recommend you open the consultation by asking the pain score, followed by, is that an acceptable level of pain? And if the answers suggest a more holistic pain assessment's needed, asking about sleep, mood, anxiety, function, and fatigue. That will allow you to then give evidence-based therapies for all of those areas. Top line for the guidelines are if your patient's leaving the room in pain and not knowing why they're in pain, then I think that's a failed consultation. Second is the pain assessment is to find out whether the pain level is an acceptable level, and if it's not an acceptable level, what's going to be done about it. Guideline gives 5 medication options and 8 non-medication options. These are change the DMARD, steroids, non-steroidals, non-steroidals, and evaluating for mood disturbances that might lead to medication if there is an appropriate need for that. The non-pharmacological options are sleep management, usually with CBT rather than medication, mood management, including psychological. Fatigue management is important, does not seem to impact much on pain, but many of our patients in pain need their fatigue managing. Education to explain why the person's in pain. Weight management. People who lose weight have less pain. Peer-to-peer review. And then there's occupational referrals to think about jobs, change the environment, and perhaps most important is exercise and movement-based therapies with physiotherapy. It's overwhelming that people in pain, if they move more, have less pain. Psychological support is overwhelmingly positive for our patients. There were many systematic reviews demonstrating this. And although the treatment sizes are perhaps smaller, there are undoubted benefits from this. The third area, which was a surprise, is health beliefs, explaining to people what the cause of their pain is, and then if there are persistent pain without an obvious cause, evaluating health beliefs with an expert, such as a psychologist, would improve outcomes over 12 months. This guideline is for the long term. We hope it's going to have a serious impact upon the quality of conversations with patients in our clinic. Success will come from our patients. They will tell us that they're in less pain. They will say they're better connected to the rheumatology team. They will have better quality of life and better health outcomes. A lot of people think that persistent pain is not changeable. It's there. The evidence does not support that. The evidence suggests it's very changeable if the right assessment's done and the right medication and support for that patient is put in.